Preview.
Diagnosis Before Treatment by Marty McCafferty. The diver was a 58-year-old male with more than 400 lifetime dives. His only medical history was hypertension, which was well controlled with a single prescription medication. His general health was good, and he was reasonably physically fit. The diver performed a single boat dive in calm, warm water, about 24 degrees centigrade at 24 meters for 30 minutes on air. Neither he nor his buddies experienced any problems during the dive. They performed a 3-minute safety stop at 3 meters, and after surfacing, they returned to the boat and began to remove their gear. Within 5 minutes of being on the boat, the diver lost consciousness and collapsed onto the deck. His buddies determined he had a pulse and was breathing on his own. Emergency oxygen was not available, and the two buddies immediately weighed anchor and headed for shore. While en route, they called 911. The trip back to the dock took 15 minutes, and an ambulance was there when they arrived. After securing the vessel, the buddies drove to the hospital just a few minutes behind the ambulance. When the buddies arrived, the emergency department were expeditiously evaluating the diver. At that stage, he responded only to pain, and the strength of his right side was markedly diminished relative to the left. His left pupil was normal size and reactive to light. The right pupil was dilated and responded sluggishly to light. He had a strong regular pulse and spontaneous respirations. After a short period, his breathing became more shallow and less regular. When the buddies inquired about their friend's condition, they were informed that he was on his way to X-rays and for a CT of his head. The dive buddies were disturbed to learn that he was not already on his way to a hyperbaric chamber. They were understandably concerned that their friend may have sustained arterial gas embolism, and they took issue with the doctor's decision to perform a head CT rather than immediately referring to the hyperbaric chamber. Both buddies independently contacted Dan and expressed concerns about the loss of time. But the Dan medics explained to the callers that obtaining a head CT was advisable. Despite the buddies' conviction that the diver had sustained an arterial gas embolism, it was in their friend's best interest to make sure that the condition had no other cause. However, the medics' assurances did not abate the buddies' fears. They both insisted that Dan medics speak to the attending physician and explain that the treatment in a chamber was most important. The Dan medics again agreed that AGE was possible, but they reiterated the other causes had to be ruled out. The head CT showed bleeding in the cerebrum. In other words, a hemorrhagic stroke. This was due to a perforated cerebral artery, and the diver was immediately taken to surgery, and during surgery, a bleeding aneurysm was found, a weak area in the artery. Aneurysms may be acquired at birth or may develop as a result of high blood pressure. After successful repair, the diver was admitted for neurological intensive evaluation and care. The initial bleeding had caused swelling of the brain, and this resolved over the next 2 weeks. During that time, the diver regained consciousness, remained stable, and began to recover strength in the right side. He was transferred from the ICU to a rehabilitation facility where he spent 3 months undergoing physical and occupational therapy. He recovered enough function in those 3 months to allow him to return home, and within 6 weeks of being home and continuing to undergo therapy, all the deficits resolved completely. Stroke is one of the 3rd leading causes of death and the leading cause of long-term disability in the United States. While arterial gas embolism was certainly a consideration in this case, determining the presence or absence of a stroke had to take priority. While few clinicians are dive medical experts, decompression illness remains rather rare and is most often a diagnosis of exclusion, meaning that there is generally another possibility that needs to be ruled out first. The need to review alternative explanations for divers' symptoms was particularly important, given the lack of any rapid ascent or breath holding. It was therefore very unlikely that diving contributed directly to the rupture of the aneurysm. It is important to recognize that not all signs and symptoms following dives automatically indicate diving accidents. As this case illustrates, signs and symptoms that suggest that decompression illness may actually represent an entirely different problem is important enough to consider, and in this case, the treating doctor very wisely referred the diver for examination to explain why there was unilateral weakness, pupil dilation, and sudden loss of consciousness. Dan frequently consults with emergency departments and provides dive medical advice and information. This can assist clinicians in making accurate diagnoses and, in the case of decompression illness, where recompression chambers may be found. While prompt treatment of decompression illness in a hyperbaric chamber is the general goal, ruling out other serious explanations must often take precedence. In this case, delaying surgery by 5 or more hours could have resulted in lasting neurological deficits. In the end, the goal of medical practice is to apply thoughtful diagnostic approach to symptom presentation and to determine the most effective, most appropriate treatment.